Hi, my name is Bob Davis. I'm the Chief Operations Officer for Research Point in Austin, Texas.
And I'm John Rogers, Research Point's Medical Director, also based in Austin, Texas.
We need to be a little bit better in what we're including and excluding. It's a very difficult thing. You sometimes have class effects that you have when you're doing drugs, and you have to have certain ones in there, but you're afraid of certain things, and you just put everything in, and before you know it, you don't have a study that's enrollable.
Yeah, and in fact, pharmaceutical sponsors sometimes cone down on very narrowly described populations, but use that to seek broader claims in the overall population. And as you know, the data are what the data are. So if you define a very narrowly defined population, then that's what the claim structure will be. But that's usually not the objective of most companies that seek approval in broader populations.
We find out that less than 20% of all clinical studies enroll within their time frames. And it's all about identifying the patient population. If you can do it beforehand, it's great. If it's a chronic disease, it's much easier than if it's an acute injury. Success in one study does not guarantee you success in the next study. Things change. There's competition for patients. There's competition within the office. There's pressure that's put on the coordinators to find the patients, again, from the investigators. But
That and study coordinators, and they're great people, but if you have a study that's too complex, I think some of them will pace themselves because it's just too much work to do several patients with highly complex multiple sticks, multiple samples, multiple testing procedures, and so forth at each visit. And sometimes the enrollment will be capped by the coordinator because they're going through a lot of steps in collecting data because it's a very data-intense study. And that's where, as you pointed out, having a phlebotomist to come in to help with some of that work, or an ECG technician, or a nursing assistant to collect serial vital signs, decompresses the study coordinator, allows her to go out and aid in the recruiting effort and so forth.
But in my experience,
Having highly segmented markets where there's one major television network bathing a city, for example, Indianapolis, Lexington, Louisville, for example, where the catchment area is defined by the investigator site and the media that surrounds it, seem to work pretty well. The other situation where I've seen where mass media might be useful is if you are treating a disease that's prevalent in the community, for example, like you've got a therapeutic for influenza, for example, or viral meningitis. If you have a local outbreak, you could use media campaigns to advertise for patients with acute symptomatology.
we just finished a study in acute low back strain that we enrolled in 3 weeks using a media campaign, where we anticipated it to take 4 months. But because it was an acute injury and they needed to come in and be seen within a week of injury, there was no way other than advertising that we were really going to be able to identify the patient population.
one of the things that has struck me as being very important is ways to improve enrollment metrics. And there's a number of tricks over the years. People have used advertising, for example. I mean, have you seen anything else that's been novel or different?
Well, I see the social networks that are trying to creep up now, whether it be LinkedIn, text messaging, whatever, and Twitter, where you have a limited number of characters. The problem is you can't give full disclosure in the Twitter. It's sort of a tease, and I'm not sure how well the IRBs are going to feel about enticing patients to seek out information on the study.
You have some experience with rare diseases, so do I. What have you done recently to try to recruit patients who are very uncommon? There may be only 10 or 15,000 of them in the world, for example.
Yeah, well, obviously going to some of the support groups has been beneficial for us. We did some stuff in acromegaly using the Pituitary Tumor Network Association meetings to try and get the word out to subjects.
And in the recent past, I've done a study of chronic viral meningitis in children with severe combined immunodeficiency, and there may be only 20,000 children in the world with that condition, and maybe only 2% of them are infected chronically with certain enteroviruses, but this may be 1 or 2 children per center, and maybe 30 or 40 centers around the world that have a child that's infected. So it's a rare population of a rare disease, but requires reaching out to literally all the pediatric immunologists in the world to see if they have any cases